Hello, I am Erwan Lerumeur, a physiotherapist based in Paris, and I am pleased to welcome you to the weekly Pelvic Health Research Review for the 17th of July, 2026. This week, 89 publications were screened and 45 were retained. The main feature asks a simple question. When a drug, a technology, or another treatment component is added to an intervention that already works, does it genuinely improve the outcome? This review provides general scientific information and does not replace individual medical assessment or decision-making. Let us begin with the must-read papers of the week. Our first paper asks whether high and intermediate anorectal malformations should be repaired in a single neonatal operation or through a staged strategy. A meta-analysis pooled 4 comparative studies, including 746 children. 399 underwent single-stage reconstruction. 347 underwent staged repair. No significant difference in incontinence was found. The relative risk was 0.93, with a confidence interval ranging from 0.52 to 1.66. Heterogeneity was substantial. The I-squared value reached 83%, and the prediction interval was wider still. Infection outcomes could not be pooled reliably because the definitions and reporting methods differed too much. The conclusion is therefore not that the two strategies are equivalent. It is more cautious. With low to very low certainty evidence, neither approach has demonstrated superiority for continence. Our second paper concerns frailty before surgery for male stress urinary incontinence. A Medicare study analyzed 7,252 men treated with an artificial urinary sphincter or a male sling. Their mean age was 74. 15% experienced a complication within 30 days. 11% underwent device revision or removal within 1 year. Compared with non-frail patients, the risk of an early complication was multiplied by 1.5 in pre-frail patients and by 2.5 in those with greater frailty. Frailty also remained associated with revision and device removal after conventional comorbidity had been taken into account. Administrative data cannot describe the initial severity of leakage or the functional benefit achieved after surgery. Even so, the study shows that choosing between a sphincter and a sling is only one part of the decision. Clinicians must also consider whether the patient can tolerate the procedure, operate the device, follow post-operative instructions, and cope with a possible revision. Our third paper reports almost 7 years of conservative treatment for deep bowel endometriosis. 52 women remained on conservative management, mainly hormonal therapy. Their quality of life, bowel symptoms, and urinary symptoms were broadly stable. Dysmenorrhea improved, dyschezia and intermenstrual pain changed little. 15% still had a major Lars score at follow-up. In the broader analysis, 19% eventually underwent bowel surgery or total oophorectomy. Several years earlier, those women already had larger bowel lesions, more severe pain, and poorer physical quality of life scores. This is not a direct comparison between medical treatment and surgery. It does show that a non-surgical pathway may remain acceptable over the long term in selected women. It also suggests that later progression to surgery may be partly predictable. Our fourth paper focuses on preserving sexual function during prostate radiotherapy. A secondary analysis of the MIRAGE trial included 117 patients with complete sexual function questionnaires at 24 months. They had received stereotactic radiotherapy guided either by computed tomography or by MRI. MRI guidance, together with tighter treatment margins, reduced the volume of the neurovascular bundles and internal pudendal arteries exposed to low and intermediate radiation doses. A higher maximum dose to the right neurovascular bundle was associated with a greater likelihood of sexual function decline. The analysis is exploratory and includes only part of the original trial population. It nevertheless provides a plausible anatomical explanation for the better preservation of sexual function observed with MRI guidance. Greater precision may spare the vascular and neural structures involved in erection rather than protecting only the bladder and rectum. Our fifth paper compares two routes of uterosacral ligament suspension. A retrospective cohort compared 135 laparoscopic procedures with 43 vaginal procedures using propensity score overlap weighting. After approximately 3 years, composite success was 86.1% after laparoscopy and 85.1% after vaginal surgery. Anatomical success, subjective success, and retreatment rates were also similar. Laparoscopy made concomitant adnexal surgery easier. The vaginal route avoided an abdominal approach, but required close attention to the ureters. 2 postoperative obstructions required intervention. There is therefore no obvious winner. The decision is more likely to depend on the operative profile, associated procedures, and type of complication than on a major difference in overall effectiveness. Let us move to the main feature: adding a treatment, genuine benefit, or therapeutic stacking. The first example is botulinum toxin for chronic pelvic pain. This paper extends a randomized trial in which botulinum toxin type A reduced pelvic floor muscle activity more than placebo. However, it did not provide superior pain relief at 26 weeks. In the open-label extension, 27 women who had not responded to placebo received 100 units of botulinum toxin. They then received pelvic floor physiotherapy at 4, 8, 12, and 26 weeks. Their pain improved, and some benefit remained at 12 months. Taken alone, this appears favorable. However, participants who had responded during the randomized phase also maintained prolonged improvement after placebo injection, followed by the same rehabilitation program. No clear long-term difference emerged between botulinum toxin and placebo. The signal in some initial non-responders deserves further study, but an open-label extension cannot repair a negative controlled comparison. Long-term improvement may reflect physiotherapy, the injection procedure, natural fluctuation, patient expectations, and other non-specific treatment effects. The second example is the combination of mirabegron and solifenacin for overactive bladder. The reanalysis of the Synergy trial did not merely ask whether combination treatment works. It asked whether the two drugs produce true synergy. With 5 mg of solifenacin plus 50 mg of mirabegron, approximately 51% of patients reported no further urgency urinary incontinence episodes. However, the observed responses remained compatible with a model of independent and additive action. No outcome clearly exceeded what would be expected from the combined effects of the two drugs. The combination may still be useful. 2 different mechanisms can increase the chance that a patient will respond to at least one of the treatments. The benefit appears additive, however, rather than synergistic. The third example is the addition of interferential current to exercise for stress urinary incontinence. 30 women were randomized to supervised exercises with active interferential current or to the same exercises with sham stimulation. Sessions were delivered 3 times per week for 4 weeks with follow-up to 8 weeks. Both groups improved intravaginal pressures, symptom severity, and quality of life. The only significant difference favoring active treatment concerned weekly leakage frequency. For all other outcomes, adding interferential current provided no demonstrated additional benefit. With only 15 women in each group, several outcomes, and a short follow-up, this finding remains fragile. It supports a larger trial, but does not yet demonstrate a consistent clinical benefit beyond exercise. The fourth example is negative pressure treatment for perineal wounds after abdominoperineal resection. A systematic review included 8 studies. However, only 3 comparative studies, representing 270 patients, could be pooled. Perineal wound complications occurred in 36.5% of patients receiving negative pressure treatment, compared with 53.6% of controls. Despite this raw difference, the pooled result was not statistically significant. The relative risk was 0.79, with a confidence interval from 0.42 to 1.48. No clear benefit was found for infection, surgical revision, or hospital stay. The studies combined prevention on closed incisions, treatment of open wounds, and substantially different protocols. A numerical trend cannot therefore be converted into a general recommendation. The fifth example asks whether exercise itself or professional supervision makes the difference in fecal incontinence. 124 patients completed 6 weeks of pelvic floor muscle training. 64 were supervised by a physiotherapist. 60 exercised independently. Squeeze pressure and the ability to retain liquid stool improved in both groups. The supervised group, however, achieved greater improvement in the functional and social consequences of incontinence. The study was not randomized. Motivation, availability, and baseline severity may therefore have differed between the groups. Even so, it suggests that added value may lie less in a new device than in exercise selection, progression, correction, and adherence. The final example is a 3-day course of celecoxib after holmium laser enucleation of the prostate. 140 treated patients were compared with 140 matched controls. At 2 weeks, celecoxib was not associated with less urinary retention, less hematuria, or a better overall urinary symptom score. It was associated with stronger urinary flow and a higher probability of early continence. The finding is interesting. However, the treatment reflected a change in clinical practice rather than random allocation, and follow-up was very short. Celecoxib is therefore a candidate for a controlled trial, but not yet a mandatory post-operative component. The common message is simple. Improvement after a treatment has been added does not prove that the added component caused the improvement. The underlying therapy, professional supervision, placebo effects, patient selection, and time may account for a substantial part of the result. Let us move to the brief reports. A study from the Requite cohort explored the interaction between the timing of prostate radiotherapy and variants of the circadian gene PER3. In a genotype carried by 44% of the cohort, predicted rectal bleeding risk fell from 11% with treatment at 9 in the morning to 5% with treatment at 5 in the afternoon. For another variant, avoiding the middle of the day reduced predicted incontinence risk from 15% to 5%. These exploratory results require replication before radiotherapy schedules are changed. However, the idea is remarkable. At the same radiation dose, tolerance may partly depend on the biological time at which treatment is delivered. A review identified 126 pregnancies following uterine-preserving prolapse surgery. Almost 95% of deliveries occurred at term. Approximately 2/3 were by caesarean section. Prolapse recurrence was reported in 11.7%. The findings are reassuring. However, the available series remain too small to identify the best operation or the best mode of delivery. In active ulcerative colitis, 36 patients underwent anorectal manometry and barostat testing before and after treatment. Symptoms improved as inflammation was controlled, yet almost 1/3 still reported fecal incontinence, and more than half continued to experience urgency or tenesmus. Abnormal rectal sensitivity, compliance, and capacity sometimes persisted despite histological remission. Among 170 constipated adolescents, 69 met the criteria for dyssynergic defecation. A rectoanal pressure gradient below -45 mm of mercury had 86% specificity, but only 58% sensitivity. A markedly negative value therefore supports the diagnosis. A less abnormal value does not exclude it. In children with anorectal malformations, an ultrasound measured rectal diameter above 3.1 centimeters had 96% specificity for symptomatic fecal loading. Its sensitivity was only 63%. The measurement may assist monitoring within a bowel management program, but cannot replace clinical assessment or evaluation of the whole colon. Finally, among 45 children treated with an antegrade continence enema appendicostomy, functional success and satisfaction were high. However, almost 38% developed a skin-level stricture, and 1/3 required surgical revision. Let us finish with the unusual findings. Hemorrhoids or not? Among 19,364 patients treated for hemorrhoids over 10 years, 56 were ultimately found to have an inflammatory cloacogenic polyp on histological examination. All had a prolapsing anal mass. 91% had rectal bleeding. The proportion was low at 0.29%, but the diagnostic trap is real. A convincing hemorrhoid-like lesion may still deserve excision and pathological examination. And in this week's Veterinary Minute, 2 cats sustained rectal perforation during fecal sampling with a fecal loop. Both required surgical repair through a perineal approach. Whatever the species, the rectum appears to tolerate instrumental enthusiasm rather poorly. Conclusion. This week's must-read papers show that the absence of a statistically significant difference does not automatically establish equivalence. They also show that functional outcomes often depend as much on the patient's condition and care pathway as on the technique itself. The main feature reminds us that adding an intervention does not necessarily add a specific benefit. Botulinum toxin, interferential current, negative pressure treatment, and celecoxib all produce interesting signals. But those signals must be separated from the effects of the underlying treatment, professional supervision, placebo, and time. The relevant question is therefore not only whether the patient improved after treatment, it is how much of that improvement can genuinely be attributed to the component we added. Join me next week for another review of current pelvic health research.